All right, I'm back.
Alrighty.
What was the final head count for registered folks?
Let me pull it up right now. I believe it's about 25. And we've got a hand. I'll send the full attendee list over to you, Scott, after our call today. But we've got, it looks like five or so health systems, some hospitals that are surgery focused, some regional health systems, and then there's a decent chunk of VPs of payer contracting and strategy at like startups and such as well. I'll send you the full list after this call, so you got everyone's name and company.
Then you know what? I'll shoot you an email. Got a potential client in Tennessee and um, Williamson Health, and they've got a small private ED group that they need some. They need some data. Whether or not they want to pay for it, I don't know yet, but just wanted to get an idea of, if I can just put in front of them, hey, look, this is roughly what the data is going to cost you. I don't know. It may be
Totally.
too small for you guys, but take a look at it.
Yep, sounds good. All right, and welcome. I'm assuming you're going to be covering making sure that we're letting people in, and if throughout the session anybody unmutes or anything, just stay on standby and make
Yep.
sure that things are going smoothly.
Yep, I'm gonna send a blast to everybody too, saying to join.
All right, I see we've got folks starting to jump aboard here. We will get started here in the next few minutes. Welcome, everyone. We're going to just give everybody a few minutes to join here, and we'll get right to it. All right, for folks just jumping on, we'll maybe give it another minute or so, just for folks to get settled before we get started. Thank you so much for jumping on. Excellent. Well, we will go ahead and get started. And as folks jump in, we'll just go ahead and proceed. So, welcome everyone. Excited to get started here today with our webinar on staying a step ahead in payer negotiations with myself and our esteemed guest here. We are excited to be welcoming everyone to this webinar where we're going to go through a series of items here. So we're going to get started with just a quick round of introductions, both here on the Trek Health side as well as on Scott Ellsworth and Ellsworth Consulting. Then we're going to go through some of the updates from the perspective of Scott Ellsworth on changes that are undergoing payer negotiations and maybe the impact for provider organizations as we continue to work through 2025 and go forward here. Then we'll spend some time looking at new data-based approaches in negotiations, leveraging things like pricing, transparency data, and otherwise. And as we go through our motion here today, please feel free to either in the Zoom chat or as we jump along, even by unmuting yourself and jumping in, feel free to ask questions as we go along here. We've got a smaller, more intimate group, and we're happy to answer questions or share thoughts as we jump along. Just to maybe share a quick background for folks that might not be familiar with Trek Health here, we are building a software platform that we believe is the co-pilot for healthcare contract negotiations, really your tool that you should use to support you through the process of negotiating from end to end. We founded this organization in 2022 and today support upwards of 100 health systems and provider organizations across the country. I want to take a moment to introduce Scott Ellsworth, our esteemed guest, who has a long career both on the payer side and more recently on supporting provider organizations, namely large health systems, in negotiating contracts strategically with payers. Scott has had a 30-year plus career at payers like Centene, United Optum, Excelis, BCBS, and otherwise, and really is an industry leader and an industry expert in all things related to negotiations, and is tapped often by CFOs and CEOs at large health systems to support driving the approach that can help build leverage and actually do negotiations the right way. So Scott, thanks for jumping on. Welcome.
Yeah, Dilpreet, thanks for having me here, and thanks for the intro.
All right, so Scott, I'm going to pass it over to you to maybe first just go through what you're hearing today as we talk about negotiations from the provider's perspective.
Yeah, thanks. I'm looking at the camera, at least on my end. It looks like I'm bright red here, so apologies for that. I've got like this red mirror up behind my screen, and I think I'm getting a lot of reflection off of that. But I do come from the payer side.
Mr. Herbert.
I still have my horns to prove it, but looks like we might. Yeah, there we go. Somebody talking. So, but great to be here with all of you. So, I'm just going to run through a couple of share a few thoughts and ideas, and what I'm hearing from clients, and probably the number one thing that folks always start off with is just how difficult it is negotiating with payers, right? And at times it feels impossible. And I work with some very large health systems, 15 billion in revenue, 40, 50 hospitals. Trust me, even if you're, on the phone here and you're a small physician office or group, it's just as tough for the big guys. Yeah, for the big folks, the big providers, they can get people to return their phone calls, but that falls off quick. It's a real challenge to even, get a live body often versus being, maybe directed to a portal or something else to have a contract. And so there's a lot of challenges out there. I think, most providers are experiencing the challenges of denials, downcoding, slow pay, low pay, no pay policies, just making sure reimbursements keep up with inflation. It's a frankly a never-ending battle just to secure fair, appropriate payments, and so share some thoughts today on how you might want to think about approaching that. So, this is a framework that I use with all of my clients to sort of help think about, how do we get organized if we're looking at renegotiating our Blue Cross rates or renegotiating with Aetna or Cigna or anybody, where do you start? Obviously every situation's a little bit different. Every provider group's different. And so, not every step here needs to really be that complicated. but I think every step here is critical to having in place as you know embark in your negotiations. Again, depending on the size of the organization, larger organizations, national, multi-state provider groups, you know, starting early is important. You need to build a strategy, get organized. You know, do you have to start 12 months in advance? No. I get called in all the time for, you know, folks that just want help now and, you know, don't have a hard end to a contract, right? They're in an evergreen contract that maybe has small escalators, but often no escalators. They haven't negotiated their rate and haven't had a rate increase in a decade, and you know are feeling the pinch that we've got to get some increases. So you know, certainly starting early, making sure that your leadership is aligned. The bigger the organization, you know, the more folks you need to get on board, because having that alignment's really critical, especially if you get to the end of this journey and you find yourself in a, you know, a more challenged negotiation. You're using some leverage, maybe there's a potential threat of going out of network. One of the strategies that, you know, payers have is they kind of expect providers often to cave, and so they'll slow roll, you know, drag things out with this idea that the providers are going to just grow tired of this and weary. And so having your executives aligned is really important. You know, what we're going to talk more, and Dilpreet's going to talk about data and price transparency. As you can see with, you know, my first comment there, it's really a must-have today. It's frankly table stakes. If you go into a negotiation without price transparency data, without knowing where your rates are in the market, if you don't have that data, you're flying blind, right? You're flying blind. Payers really expect providers to have it, and when they don't, they often know that people are just shooting in the dark. And you know, the old way of negotiating was sort of shoot for the moon. You know, I need a 15-20% increase, see what sticks. And then the payers come back, if they do come back, you know, with 1 or 2%, or in some cases even a reduction. And then you know, your first move is to sort of cut your ask in half. You know, that's a really tough place to negotiate from. When you have the data, you know where you stand, right? It's really understanding, where are my rates today relative to the market? What's the provider group across town getting paid by Aetna? Once you have that data, and the beauty of the price transparency data is it's out there. It's you know, I'm not going to say easily available, because I know the work that has to go into with, you know, Trek and behind the scenes, but they make it easy to get at. And the beauty of it is it's the payer's data. You can show it to them. You can say, hey, you know, I'm getting paid $1. The guy or gal across the street's getting paid $1.50. What gives? And it's actually a really effective negotiating strategy. You know, contract language, again, it's in this era of, you know, increasing denial, down code, chart retrieval, medical record requests, etc. You know, there's a lot of ways for payers to claw back your hard-earned negotiating gains. And in contract language, in more favorable language is certainly helpful. I'll say this, you know, generally speaking, with the exception of some of the larger hospitals, it's very difficult to get off of a standard contract, very difficult. So, you know, you can look at some language and maybe get some small concessions, but that's an area that, you know, generally harder for some of the smaller practices to be able to achieve. You know, where I think a lot of folks had on the last slide, no one returned my phone call. You know, it's not just negotiating with a live body, but ultimately getting to the right people. Contractors, especially frontline folks, often not very empowered, especially in a more complex negotiation. being able to get to some of the higher level executives can make a big difference. And then I'll talk a little bit more about sort of leverage and using your leverage. What you'll hear me say on this call is you really can't punch your way to, you can't threaten your way to a better contract. But providers have more leverage than they realize. And so being strategic about that and knowing what leverage you have, when to use it, how to use it, really important. So there's a lot on this slide. I think the Trek folks are going to share the slides after, but just to hit a few here. My old colleagues hate when I say this, but the reality is payers, really rarely negotiate in good faith. They use leverage. And the point is, so should you. And so just understanding kind of what leverage you have, whether it's, I'm in a market where there's an imbalance of supply and demand. There's not enough doctors. That's a reality nationally, and something that creates leverage on the side of for providers. Understanding that your patients are loyal to you. Right? They're loyal to you. They're not loyal to the insurance companies. The insurance companies are, think of it like credit cards. I mean, yeah, maybe Discover Card. I like the cashback bonus over Visa, but at the end of the day, they're kind of all the same. They're undifferentiated, and again, that can create some leverage. Probably more importantly, it's just knowing, the things to not do, or the things that would deleverage you at the negotiating table. And, talking about the wrong things, falling for some of the payer tactics, right, of arguing payer profits or premium increases, maybe negotiating different parts of your business, especially if you're, maybe a hospital, or you've got multiple service lines that you offer. Unbundling yourself, so to speak, at the negotiating table is never smart. But again, it all depends. Certainly, it's harder from the smaller you are, often the less leverage you have. But every provider has some leverage, and it's just, again, kind of understanding the market, the dynamics, thinking that through, and the right timing to use it. So maybe you want to jump to the next slide. These are just a few kind of little tactics, thoughts to consider as you're negotiating with a payer. I won't cover every bullet here, but this idea of, anchor on the facts and the data. Facts are stubborn things. This is back to the price transparency data, understanding where you are in the market, having that data. It really establishes credibility. It says you've done your homework, you know where you are, what you're getting paid, your value in the market, and you're just looking to get, fair payment. Providers are on the side of the angels. At the end of the day, the payers can never win in any type of a fight with a provider. And remain on the side of the angels, right? Make it about patients first. Take a moment to educate contractors a little bit about your practice and what you do and the people you serve. That's important. It's important to remind them, kind of what are we talking about here? We're talking about people and keeping people healthy. That's what we're talking about. Be consistent, be resolute in your approach, but, have a plan, stick to it. Don't be all over the board with what you're asking for. You're going to have to be prepared to negotiate, but at the end of the day, doesn't mean be inflexible. You're not, rarely do you get what you ask for right out of the gate. But yeah, you want to be consistent how you think about it. Escalation, again, depending on the situation, the group, who if you bring in outside help, who knows folks, that can be helpful. They typically have, contacts, but just recognizing maybe, is this person I'm talking to really empowered to help me? And should I talk to a higher level? Again, especially if there's a relationship there, it can really be a powerful tactic. Again, I mentioned, the idea of pain and leverage. It's hard to punch your way to a great deal, but just think through, leverage points, and how they may or may not be used. And, ultimately, just know that if you come to the conclusion that we just can no longer take this insurance, the rates are that bad, despite best efforts, really focus on, how do you retain patients. And the easiest patients to retain are seniors. Seniors just don't change doctors, right? They just don't change doctors. They're incredibly loyal to their doctors. I had a broker once say to me, seniors don't change two things. They don't change their pastor, and they don't change their doctors. And so the point is, if you are forced to go out of network, thinking about the timing, syncing it up with the annual enrollment period, how you communicate with your patients, et cetera, is really helpful. To the extent you can anticipate payer moves, payers are pretty simple. Their playbook is all the same. It's generally, kind of, they're going to try and slow roll you. They're going to try and convince you that you're being paid fairly. They may or may not show you data. At the end of the day, they just have a way of never saying yes. They might not say no, but they just never say yes. And knowing those steps and what they're going to do helps you kind of, in anticipating them, helps you to not be thrown off your game, because that's what they're going to try and do, is throw you off your game and then get you arguing about something other than rates. And so a few other things down here in terms of just, closing the deal and know your deal breakers. And look, some days you just take a little bit's better than nothing, and you live to fight another day. It all depends on the situation, but just remember, and I know it feels at times sort of daunting when we're talking about the consolidation. The payers, these big payers are, they're just enormous, but their product is the network. You are their product. All the payers on this call, you're the product for these payers. That's what they sell. They sell networks, and without networks and participating providers, their product's not as good. And just continue to remind yourself of that. The end of the day, them paying you fairly, right? What I've laid out here is not how do you get 20% above market. If there's somebody that says they can get you 20% above market, well, I'd run, but at least do it on contingency. But the reality is it's about fair payment. I worked with Trek for a while, and Dilpreet's heard me say, I target 75th percentile. I want to know, not that we, don't want top dollar or top money, but at a minimum, you shouldn't settle for average pay, because the minute you negotiate average pay, everybody else has negotiated a bump, and next thing you know, you're back at the bottom of the barrel. So target something a little bit higher. Yeah, and I think maybe wrapping up here, it's just have a strategy. It's shocking to me how I find a lot of groups, and often large, sophisticated provider groups, sort of approach contracting from more of a, let's say, transactional mindset. Like, oh, we got this contract renewal, we got to get it over with, and really not taking a little bit of time just to say, what's our strategy, what's the data tell us, what relationships do we have, what are the market dynamics, and that can really pay off with just that type of work. Again, I've beat leverage and that talk to death. And the last plug's just a shameless plug. And then did I have one more slide, Dilpreet? Yeah, I get asked this a lot, kind of, well, what else are your clients talking about? And, that's just a few things that's not really for today's agenda, but Medicare Advantage, it's sort of a should I stay or should I go, frankly, analysis on MA, given the low yields. Watch out for ACA. ACA, Obamacare is going to continue to cannibalize commercial revenues. Pay attention to what rates you've negotiated for ACA. When ACA first came out, yeah, it was Obamacare. It was for the uninsured. All the payers were offering a slight premium to Medicare. And at the time, it sounded great, right? We're going to take all these people with no insurance, especially for hospitals, folks showing up the ED, and we're going to get paid. Wonderful. Well, fast forward, a dozen years, we got 20 million Americans in the ACA, and small businesses are starting to basically say to their employees, go buy your own insurance. You can buy it better than I can get it for you. So we talked about a few of the others. Just how do you really address some of the slow pay, low pay policies? Not easy. And the administrative burdens. What can we do there? And those are certainly things you should be addressing at the negotiating table. Are you going to get full relief to all of that? No, but addressing it and at least getting something is worth the effort. So I think I'll stop there and turn it over to Dilpreet.
Yeah, thanks, Scott, for the walkthrough here. And if we have time at the end there, I'd love to dig into some of those points, but appreciate the walkthrough on both the strategy that one should align on proactively to negotiate, and then how we can sort of think about leverage in real terms. I'm going to spend a few minutes here going through here at Trek Health how we recommend driving strategic decisions and decision making with these pricing transparency insights. So as a starting point, what I want to just call out is that as of 2025, most health systems and provider organizations are saying that if you look at the top stack of your priority list, really number one is to develop growth strategies, whether that's top line revenue growth based on the service lines that we're already operating today, or expansion into net new areas. As well as other things like addressing workforce challenges, cybersecurity, et cetera. And as we look at these areas, I think there's actually multiple sections that pricing transparency can touch in supporting these enterprises. Growth strategies, I think, in alignment with what we're talking about here today, we can really use this pricing transparency data to figure out how we can reprice our contracts, and that poses great growth opportunity in and of itself. But there's also growth strategies in the context of exploring net new service areas, where you can actually research within the pricing transparency data to figure out what a profitable service line makeup might look like based on theoretical market rates or your existing contracts. The pricing transparency data also allows you to go out and explore net new markets that you might want to grow into, or states where you might not be familiar with the reimbursement landscape, so that you have an edge as you go in and start to expand out your organization. From a workforce perspective, one thing that I just want to touch on briefly is that the pricing transparency data contains not only data at the level of the facility, but it also contains data at the level of the individual physician or provider. So if you as a organization want to understand the makeup of the specialty organization that does orthopedic surgery for a competitive health system or a competitive practice, you can actually, with this pricing transparency data, not only see what the makeup of that competitive facility looks like, but actually who are those physicians and who are those providers that organization has hired, and do strategic decision-making with the data as well. And a bunch of other things, but moving along, just so that we're clear, I want to spend a moment also highlighting the source of this data. So the transparency and coverage ruling was put out initially in 2020, and really 2022 to 2025 has been the 3-year period where we've seen most of this implementation going into effect. And the long story short on this is that there's a hospital component that requires health systems and hospitals to publish their charge master. But more importantly, there's a health plan component that requires every commercial health plan across the country to actually publish every contracted rate for every provider across the board for every service line. This is getting hosted and published by the payers themselves, and Trek Health has gone out and ingested every contracted rate for every provider and every payer across the board. To give you some context into the data itself, there's over 10 million combinations of all these unique billing codes and service lines. So the data is very dense. There's a lot of data that's getting published. And it's been roughly 2 years since the data has been posted here by payers. And there's been pretty significant changes in both the volume and the compliance across the board here over the past 24-month period. Many on this call might already be familiar with what the data here looks like in practice, but just as one real life example, Trek is based here in the San Francisco Bay Area. Just as an example, E&M 99214 for a variety of different organizations in the San Francisco market, you can see a 500% variance in rates just for the same service, same place of service, same physician type, simply based on the contract. We all sort of know this in behind the scenes, but seeing it at the level of the individual organization and being able to use this as leverage as you walk into your negotiations, from my perspective, changes the game. What we do here at Trek to support our partners is, first, we're actually going out and working with you to consolidate not only the pricing transparency data based on your use case, but also relevant data from our partners. So we would work with our partner organizations to take things like utilization data and other key data sets that we can help use to really build out the story involved in the analytics that we need to do behind the scenes. Once that data has been consolidated, typically that would look like utilization data, pricing transparency data, creation of service lines, making sure that we're seeing things apples to apples. We would then go out and actually conduct the analytic works on the back end. And typically that involves doing a deep market analysis to compare your contracted rates to what we're seeing within the market to help identify where there might be bright spots or opportunities for us to renegotiate things that you might not have otherwise seen. And then we can go out and pull those specific insights for you. So this is a process that we are working on deploying for our customer base so that throughout the negotiation lifecycle, end to end, you can simplify visibility into fair reimbursement. So maybe to candidly pick on a health system here in the Bay Area that we went ahead and ran an analysis for the sake of this webinar here today, I wanted to just showcase what the power of this can actually be in real terms. So this is Alameda Health System, here, a health system based here in Northern California, not a Trek Health client. We just picked a health system here totally randomly. And what we did is we went in and said, look, we're going to use our intelligence to go out and identify the top 10 service lines for this organization based on the facilities and the providers that are associated to the tax ID of Alameda Health System. We've identified the emergency department, lab services, and a bunch of other key service lines that are likely important for this health system. And across the BUCA payers here, the top 4 payers in the Northern California market, what we did is for each service line, you're actually seeing the reported rate for Alameda Health System as a percent of the market average. So 229% here for emergency. For the emergency department for Aetna is representing a 2.29x rate that Alameda Health System has actually secured versus the market average. And you'll notice that there's interesting dynamics at play here. In some cases, as an example, their Aetna contract looks like they're doing relatively well across the board. For their Cigna contract, it looks like when you narrow in on certain service lines like their sleep department, they're doing relatively well from a reimbursement perspective there, but not in many other areas within their organization. And same is true for each payer as we go through this. You can start to actually pick apart. This is, of course, at the highest level, the 10,000 foot level, but with the pricing transparency data, you can then go in and actually look at the billing codes, the reimbursement rates, the specific competitors that you're comparing yourselves to, and many other things. And so this is just one example of what we can help produce for your organization through working with Trek Health. The pricing transparency data, as Scott mentioned earlier, is definitely not easy to work with in raw form. There's a lot going on there. But the power of it is that since the payers are now forced to publish this in public domain at the level of the NPI and the tax ID, we can take this and roll it up into views that would be meaningful and powerful for you and your organization. So with that, I want to just pause here and take a moment to maybe dive in, Scott. We've got an extra 10 or so minutes here or before we need to formally wrap up. So if there are any questions in the audience, please feel free to use either the Zoom chat here, or you can go ahead and unmute yourself and chime in. One thing I'd love to get your perspective on, Scott. In your slides, you mentioned leverage. And one of the things that you mentioned considering as leverage within the negotiation is government programs. So Med Advantage and Managed Medicaid plans. So can you maybe, for folks on the call, elaborate on how you see in negotiations government programs being used as leverage?
Yeah, so right, government programs. I'm thinking of Medicare Advantage, Medicaid, and ACA. And even though I think ACA is really commercial, it's still, government sponsored, certainly government subsidized. And so, really simple on this one. Think about, again, depends on the group. So nothing always is just an absolute. It really does depend on the situation, but generally, so we're in a weird business. So the highest margin business for a payer is government program business. If you listen into any of the earnings calls, they always lead with Medicare Advantage. That's what all of the analysts want to know. How you doing in Medicare Advantage? ACA business is a very high margin business for payers, high single digit margin business, mid to high. Medicaid is a pretty good business, and there's a lot of stability now in managed Medicaid. If you look at sort of who the plans are in the markets, they tend to be the biggest for-profit, publicly traded. And so, in the payer world, it's the government business that's actually where they make most of their money. Do they make money in commercial? Sure. But the self-funded business is just a TPA fee, and it's a little bit of a different world. Now take the providers. It's the inverse of that. The highest margin business is commercial, and the lowest margin business is Medicaid, followed by Medicare Advantage, followed by ACA. And so, by terming only government programs, that's really the play there is, do you terminate government only programs, thereby sort of preserving as a provider, your cash cow, the commercial business, but saying, look, we are going to term our government business because the margins are so low. Now, the business, I think everyone knows, commercial subsidizes government programs. It's just the way it's always been. It's the way it is. But yeah, that's a way to potentially sort of de-risk yourself, create some leverage without putting your core business in jeopardy. Depends on your contracts, depends on your market, but it's just maybe a sidebar on that for Medicare Advantage. If you read Becker's and some of the others, there's providers are getting out of Medicare Advantage in droves. The reimbursements, the yields are 85 cents on the dollar. Down coding, denials, bad debt is a huge issue. Look at some of these MA plans, $8,000, $9,000 max out of pockets. I mean, they're great plans because they're free until you go to use them, and seniors find out, holy smokes, I've got a lot of cost share, and collecting that can be challenging for a lot of folks. So looking at your MA plans and maybe saying I don't need to participate with everybody. Maybe you should participate with half of them. You can probably improve your MA margins by 300-400 basis points just by dropping the bottom half of the performing MA plan. So yeah, there's strategies there. It's this negotiating business is not about getting somebody a windfall type of rate of a 2x. It's really, kind of the ongoing hard work of, instead of negotiating a 1% increase, get a 3.5% increase. And, you do that a couple times, and next thing you know, you've seen a big improvement in your bottom line.
Absolutely. Next question I have here is, so in the negotiation cycle, one thing that you brought up a few times is it's important to identify the point at which an escalation within the payer organization might be necessary to be able to really effectively negotiate. Can you give us examples of when and how to decide where the escalation is necessary, and how to actually go out and put it in practice?
Yeah, great question. So, it's, for starters, right? You have to sort of know who to get to, or have a way to get to some of the higher ups. But, and again, every situation's a little bit different, but just knowing some of the higher level leadership in the contracting team, can get you a different audience. As you sort of move up the food chain at payers, you run into people with more experience, folks who have been through it. You run into people with more, let's say, decision-making power. The frontline contracting staff of payers, you trust me, it's a thankless job, right? Everybody hates them. The providers hate them. Their bosses hate them because they think they're giving the store away most of the time. It's a pretty tough, thankless job, so to speak. You get higher up the food chain, folks begin to understand better the dynamic between the financing and delivery of healthcare. They've been through it. In the past with the terminations and they understand, more broadly the value of networks. At the highest level, right, it's really getting outside of the contracting silo and talking to a P&L owner. So the, market president for fill in the blank on a health plan, they all have them, but getting to someone who, again, is going to feel more of the impact if your health system, your provider group's not in their network, and that results in their members migrating to another payer. Again, they're going to be open to hearing about a fair and reasonable ask, right? If you get an audience with someone like that, and you say, look, you're paying the people across the street, 150% of Medicare. I'm getting 120. I'm just asking to be paid what everybody else is getting paid. That's an argument that's difficult for any more senior executive payer to just say, I'll ignore it, or that's not a fair argument. It's going to resonate with them. So yeah, how soon, how quickly. Often I just say to folks, you have to let it play out a little bit with the frontline staff, but we're talking about weeks, not months. And once you start to get frustrated or they're not responding quickly, that's the time to kick it up a notch. Again, strategy 101 with payers is just slow roll, and not respond to you quickly. Let the clock run out.
Absolutely. Maybe final question here, Scott. So one of the things that was outlined in the presentation is we can't always expect payers to be negotiating in good faith. In fact, one should expect that if the negotiation leads to this being the case, it's possible that there could be things like scare tactics being put up by the payer, letters to the board, SIU, program exclusion, otherwise. Any recommendations for health systems that are maybe in the thick of the negotiation and the leadership team might be sort of at the brink of deciding how to push back and how to approach these scare tactics that are being deployed by the payer? So maybe if you could elaborate on that, and any recommendations for what the health system exec should be doing.
Yeah, so the bigger your provider group, the bigger the impact on the payer, right? If we're talking about a potential out-of-network situation, and so they're going to fight back. If you're a smaller group, they may not push back as much. And again, it depends on the market dynamics. But certainly for larger groups, really important, back to this idea of executive alignment, having a strategy, walking people through in the beginning, and then regular updates and communications. So as these things happen, you're talking about daily communications with all of the stakeholders, right? Not just the leadership of the hospital, but thinking about how do you communicate with the board? How do you communicate with the physicians, the employees, regulators, legislators, media, if it comes to that, and just being prepared operationally, again, puts you in a very strong position. It's back to this idea of just sort of no bluffing, right? If you really do get to the point where you're talking about termination or issuing a term, which, embedding a term notice as part of a renewal plan is not that big a deal. But if you start to get close to that date, you're 60, 90 days out, thinking about how you begin to operationalize that, it's a big lift. It's no small task. If other, like the old, a lot of the old ways, what I've seen on the other side of the table is providers would issue a term letter and then negotiate to the 11th hour, kicking and screaming. But at that point, it's December 31st, open enrollment's over. I knew I had them as a payer. There was nothing they could do. They couldn't afford to go out of network. And sure enough, I'd let the clock run out. They would cave, or we'd offer a few more breadcrumbs and it'd be over. So it's really a different strategy of, 60 days out, you set deadlines as to when you need to have a deal. If those deadlines aren't met, then you have to take actions. And that could be sending patient letters, reaching out to employers, brokers, again, the community, the media, press releases, to, twofold, make folks aware that that this could happen. You could be out of network if you're not able to come to a new deal. And of course, it does put a lot of pressure on the payers.
Absolutely. Well, thank you, Scott, for joining us here today. And thank you to all the attendees for jumping on and listening to us talk about payer negotiations and data. We will go ahead and follow up with all of these materials via email. And if you feel that your organization could benefit from access to pricing transparency data or from access to Scott in helping actually drive the tangible negotiations, we would love to work with you and see how we can put the collaboration into practice. So thank you all. Hope you have a good rest of your week. Talk to you soon.
Thank you.